Previously on Health Garage.
Acute kidney failure is potentially reversible. Identify the cause, take away the offending organisms or substance, and then the function returns.
Without consent, there can be no organ transplant.
Everyone who has got end-stage kidney disease needs a transplant.
You're watching Health Garage. This week on Health Garage.
You cannot literally pluck organs from people and deliver them to destinations far off when they're still viable. So those stories of organ trade are just stories for the bar, to make people laugh. When people have run out of kabozi, they want to sound sophisticated. Now they come up with a story which the common man doesn't talk about. But for that trade to take place, one, we must start transplanting. When you hear that Mlago is transplanting, open your eyes, because then the possibility of organ trade is there.
Exploring organ transplantation, separating facts from fiction, myths and misconceptions surround organ transplantation worldwide. What's your understanding? Subscribe to our YouTube channel and follow us on our social media platforms for more informative content. This week, consultant urologist and transplant surgeon Dr. Frank Asimwe Rabinda from Mulago National Referral Hospital sheds light on the truth. Welcome to the show, Doctor.
We have a couple of myths and misconceptions that are running around the communities. And one of them is that when a donor, if you're an organ donor, you cannot be saved. So how true is that?
Okay, let's begin by saying that right now we don't have organ donors in that kind of sense. I will qualify that because that's not absolutely correct. Right now we don't do transplant, and when we start, we're going to start with the living donor program. Even the patients who are traveling to India, Turkey are going with the living donor program. So a person who has an organ that has failed, kidney usually, liver sometimes, reaches out to their relatives, and then one of them who matches says, okay, I'll donate. Now that person who has already said, okay, I'll donate, they are not at any risk for now from the doctors. The question applies to when we start the cadaveric program, the deceased donor program. And like I said earlier, people will be encouraged to will that if I die and my organs can be used, please use them. Now, one, you don't know when they're going to die. Two, but most importantly, they are never cross-matched with the people on the waiting list. But most importantly, the doctor has no reason to refuse to save a life of a potential donor over the life of a potential recipient. We swear the vow to sustain life. And so there is no reason. Of course, those of you who are not doctors don't understand this probably, but those who have the same spirit may understand. To me, these are two human beings. This one is healthier than this one. Why should I disadvantage, or for that matter, get the person who is healthier to die for the sake of the one who is sicker and might actually die? So one, it doesn't make logical sense. Two, it doesn't fit in our ethics. We are always sweating to save lives. I'll give you a personal example. I used to work in Kasese in the 1990s. That's when the ADF war was going on. I was brought, rebels came into my care. I remember one particular one. This had been a very notorious rebel leader who had been planting landmines and had blown up UPDF soldiers, had blown up civilians. He had lost a leg some time back. He had lost an arm some time back. And now the mine had blown him. He had lost an eye. But we worked tirelessly and saved this person's life. Yes. Even the soldiers who captured him in action saved his life, yes, and brought him to us to save his life. So in our practice, similar with the soldiers, even on the front line, yes, If someone has been shooting at you and now surrenders, I mean, that's how bad it is. Someone has been shooting at you, but once they surrender, they should be safe in your hands. How much more for us doctors who are not in any conflict with anyone? Why should we disadvantage, or for that matter, surrender someone to death just for the sake of getting his organ, to put it in another one? It might not even make it to that person. The other person may even die before they receive it. They might even get rejected and they die. So it doesn't cut it. So organ donors are safe. And the program is meant such that there is no disclosure of who matches their organs. So they are very safe.
Okay. So doctor, some people also say that if you are brain dead, you can actually be well after your injuries. How possible is that?
That's a tough one. And that's like the holy grail. That's that's the thinnest line, I should say. Brain death is not a walk in the park. Confirming brain death is not an easy thing. But there are some telltale signs. Not just telltale signs. There are signs and symptoms, and there is a criteria upon which you best say that this person is brain dead. I may not go into it, but suffice to say that the team in care who are not part of the transplant will be the first one to say that this person is brain dead. The first sign is when your brain functions cannot support your respiratory functions. You can't breathe. And the life support machine must breathe for you. Fast forward, among other signs, there is what we call the EEG, electroencephalogram. There is a machine they're able to put on your brain, and it reads the way they put on the heart, and it reads. And suppose it should read and you say, this is flat. This will not wake up. So the team which is caring for the person is the first one to declare that this person is brain dead. Now, if you're now moving into the realm of transplant, then the transplant council sends an independent team to counter-confirm. It is after these two confirmations that the person is said now confirmed brain dead. You can go ahead and harvest these organs. So again, although it's a thin line, we are used to this. The medical practice knows when to declare. Because again, if any of you has ever had a patient in the ICU, I'm sure there's a point when you have been called and told, we are not making it out of here. And you've been asked to make a decision whether to switch off the machines and the person goes to rest, or keep the machines going and he can remain in that state for the rest of his life. And I'm sure some of you watching me and listening to me have made that tough decision. It was after the team in care decided this person is brain dead, irreversibly brain dead, that then you have been asked to make the tough decision, say, okay, switch off. And some people have made that decision, and those are the kind of people from whom we harvest organs in the deceased donor program.
So Dr. Frank, there's also something that people believe because of their lifestyle choices and the way they live, they are not able to donate.
We leave that to the experts. You may be drinking 100 bottles of wine or whiskey and you think you are a wreck. If you are willing to donate, just say you are willing to donate. They will assess and they say your kidney is rubbish, but your liver is perfect. Your cornea is fine. By the way, at the beginning of this interview, I told you there are organs, tissues, and cells which can be harvested and stored. These ones include skin. There is no rubbish skin. We will be able to get skin from you. Cornea, that can be got. So even if your liver or your kidney is dead, we may be able to get skin, we may be able to get bone marrow, we may be able to get cornea. You never know. Just leave it to the experts to assess an individual by individual. So, one, be willing. And you know the willingness comes from the fact that when you are dead, and if you are buried with your organs, they are useless to you in your grave and in the life hereafter, most likely. And yet, they could have saved 11 lives. And those 11 lives, some of them may be your relatives. Some of them may be your friends. Some of them may be your classmates, your schoolmates. So instead of going down the grave with your organs, which are not going to help you, just will them and leave us say, this kidney is rotten, but this pancreas is fine. Secondly, I am aware that it is a law. You know, we clamor for going to the middle income. But in the developed world, it is a law that anyone who dies must have a post-mortem. And you know what happens in a post-mortem? I will tell you. You see where my tie is? Just beneath it, that's where the cutting begins. Okay. They cut from there right up to, we call it a zymphy where my belt sits. Okay. You are cut open. They remove from your tongue is removed, the trachea is removed, yes. The gullet, the esophagus is removed, the lungs, the kidneys, the lungs, the heart, the liver, the kidneys, everything is removed during a post-mortem. Yes. What do we do during post-mortem? In post-mortem, you're trying to find the cause of death. Okay. All those organs are removed. First of all, they are looked at and described. Someone describes them. The tongue looks like this. They are weighed. The tongue weighs this much. The heart looks this. It weighs so much. Then they are chopped into slices, like slices of bread, and studied even further, because you may look on the top and you can't see. Now, when you slice it, you're able to see more. Then they are sliced even further to get samples put in under the microscope. They are sliced even further to get juices squeezed out so they can do toxicology. And after all that has been done, they are incinerated. They are burned. So if your patient has died in hospital and the post-mortem has been carried out, they have been buried with no organs. Absolutely no organs. And that is by law. And the law exists in Uganda, by the way. So if you die in hospital and the post-mortem is carried out, those organs are thrown away and incinerated. Now, so question comes back. If those organs could save 11 other lives, why should they be incinerated and not save 11 lives? But when we start the kidney transplant program, and I'm going to be back on this program, we're going to rub this in a little bit more so that people understand that you are living with organs that could save another life, which are not useful to you. And that way, we'll have more people willing to donate. And by the way, in countries, in the first world now, they now call it the opt-out. Everyone is assumed to have consented to have their organs harvested when they die and the organs are useful. It is only when you expressly write that I do not want, yes, that you opt out. So as we develop from the low-income country to middle income to first world, it will be assumed that all of us have consented that organs can be removed. Okay.
Some people also have fear of disfiguring their bodies when they donate. Is that true? Does your body get disfigured?
After donation? Well, you know, it's a matter of perception. Let's begin with the ladies who are most fascinated about their body structures. If you have a cesarean section, does your body get disfigured? I don't know. I don't have an answer. You probably will tell me. The process of organ harvesting bears in mind the form of the person after donation. So, and since none of the organs we remove have, for instance, been bulging out, so you say, oh, you know, I had a big tummy, now I donated, now I have a small tummy. So generally speaking, there will be no notice, except for an incision. Of course, you'll have a scar. That's why we say it must be out of love, because no amount of money can compensate for what you go through, for the scar, for the pain, and the regulations that we're going to put on you, the health advisory we're going to give you. No amount of money can compensate you. It must be done absolutely out of love.
Okay, some people cannot donate blood, so they also believe that because I cannot donate blood, I also cannot donate my organ.
It's okay. Leave those ones. We don't want their organs. I mean, if you can, why should you not be able to donate blood? So if you have reasons, whether religious or tribal or otherwise, for not donating blood, it's okay. There will be enough organs. But I would like to listen to some of those reasons and see if they hold water. There may be myths. If there are myths, we can bust them. If someone is strongly, you know, for some reason say no blood, because if you can't give blood, then really getting an organ out of you is a waste of time.
Okay, so Dr. Frank, that drives us to our next question. What is the importance of organ transplant?
To save lives. To give someone a second chance, second lease of life. We're going to look at the people who are who are undergoing dialysis. I'm not sure whether we've got the consent. But their organs have failed. They have failed. And yet some of them are very useful people. Young, very young. We've got under 10-year-olds who are under dialysis. We've got 20-year-olds, 30-year-olds, people who are very productive in life. But now their kidneys have failed and they must be on dialysis twice a week. Actually, it should be 3 times a week. So they cannot leave Kampala. They cannot travel because if you go and sleep in Mbale and you're having a workshop, 2-3 days you need to be back for dialysis. So to give people that second lease of life, that's the importance of transplant.
Okay, so how do you think this bill is going to help in Uganda?
It will regulate. It will regulate the transplant once it starts. If anyone thinks of committing a crime, remove an organ without consent, or solicit money for transplant purposes, the punishments are extremely heavy. Extremely heavy, by the way. There's one I didn't tell you about. We do not, I just kind of passed on top. We do not harvest organs from children. If someone harvests an organ from a child,
yes,
life imprisonment. That's the penalty.
Okay.
They'll be imprisoned for life.
So what measures are being put up, especially in hospitals, to ensure that there's no illegal organ trade and trafficking?
Yeah, but you see, if we want any one takeaway out of this discussion, an organ is only harvested with a destination in mind and a timeline in mind. Those are very, very two important things. If I must, as a surgeon, if I must put a kidney in you, I must vouch that I've put in you a clean organ which is going to give you that second lease of life. That's why earlier on I said people have got a Sienta mentality, a mechanical mentality. I come and plug a light off this Sienta, put it in my pocket for 1 week, 2 weeks, 3 weeks, then say, hey, gundi, gundi, okay, jangu. You have no time to hang around with an organ. Once it's removed, the recipient must be in the vicinity. I've told you need 1 hour. Beyond the 1 hour, you're dealing with an organ which is not going to be perfect. Yes. I've given you the scenario for malt organs which go to various hospitals. You cannot give a young patient, okay, now I must tell you that patients who are given organs, if it's from a living related donor, they've got a lifespan of about 15 to 20 years. After about those 20 years, most organs will fail again. Now, some of those people can actually get a second kidney, another 10, 15 years. Then they might get a third kidney. So organs which are going to travel a long way from the center where they are harvested, as a compromise, you say, instead of throwing it away, let's give it to the patient in, say, Kisoro, where it's going to take 4 hours in flight. But that patient should be a second time or a third time recipient. You give it to them in full agreement that this is an organ which is going to give him maybe 2 years, maybe 1 year. And you understand it that way. But a young person who is getting an organ for the first time, actually in practice, most people who need organs, they come and camp around the transplant centers. The businesses which are going to boom around Mulago are hotels and hostels for patients who are waiting for kidneys and organs. So that as soon as they say you have a match, it takes you 10 minutes to walk into the theater and say, oh, they told me I have a match, I'm here. So that you lose no time. So this business of, there was a van parked outside Mulago mortuary, then they put in an organ which was removed in the mortuary. In the mortuary, where there are dead bodies, you remove an organ in that environment, who dares to remove it? Oh, a mortuary attendant. A mortuary attendant? Has that one even studied in anatomy? Okay, for argument's sake, let's say a mortuary attendant has watched so many things and has plucked it off. Okay, this organ gets into a cool box with ice and heads for the airport. Remember, there's a traffic jam. So the airport here, it's about 1.5 hours. Yes. You reach the airport, you have to take the organ through the check-in. Yes. Either it is carry-on luggage or check-in luggage. Who are you going to bribe? How many people are you going to bribe? The guy at the X-ray, when the thing passes, you say, hey, so call it one chino chichi. Let's imagine you have bribed that one. You reach the airport, you put it on the, are you going to put it in the carry-on or the check-in luggage. You reach Dubai and you're taking it to the Arabs. Yes. Are you able to bribe those Arabs in Dubai and do it again and again and again to sustain a trade? And that organ which you have got from a random person who has not been screened, which you have taken in very controversial circumstances, you are taking it to someone who has paid 100,000 US dollars, and me as a surgeon, this is the organ I'm putting in this man who is paying 1 million US dollars, and then 2 weeks later I'll meet him in the face and tell him, hey, how are you? Oh, the organ failed. How? So for an organ, for a trade to be sustainable, you must deliver viable products. You cannot literally pluck organs from people and deliver them to destinations far off when they're still viable. So those stories of organ trade are just stories for the bar, to make people laugh. When people have run out of kabozi, they want to sound sophisticated. Now they come up with a story which the common man doesn't talk about. But for that trade to take place, one, we must start transplanting. When you hear that Mlago is transplanting, open your eyes, because then the possibility of organ trade is there, okay? But how is it going to be safeguarded? One, every hospital must be accredited every year. The license must be renewed on an annual basis. Any transplant surgeon must also have their licenses renewed every year. All organs that have been transplanted must be reported to the Organ Transplant Committee and must be tracked to source. Frank got a kidney from Sharon. Who is Sharon? Frank's wife. X got an organ from Y. Who is Y? So-and-so's brother. Are you sure they are their brother? Should we find any discrepancy, even after the transplant has taken place, the recipient goes into prison, the donor goes into prison, the hospital is closed, the surgeon goes into prison, and then they come from there to Kubitevia. If you exonerated, say, the papers were signed, you get exonerated. If you are found guilty, you pay the price. What I also didn't mention is that every transplant, whether living donor or cadaveric, must be authorized by the council. If I need an organ from you, you must be my relative. We've got 2 levels of relation. This is what we call first degree and second degree. First degree is siblings and parents. Second degree is uncles and aunties and cousins. So for us now, we're beginning by saying it must be related donors. Those are the first degree relatives, and second degree relatives we allow. When I present you to my nephrologist that you are my relative, the nephrologist is going to fill so many papers. You must swear an affidavit before the law that I am related to this person and I'm giving this for free. Then you're going to meet the council. The council is going to interview you separately. Yes. If you say you are my sister, you must know my full names, my birthdays, my children, my wife, our father, So they're going to ask you those questions. If you're able to answer them properly, then you prove you're a relative. If you fail, that transplant will be cancelled. So every transplant will be authorized by the council. When you get the cadaveric program, like I've described, it must also be authorized. So any transplant which takes place and the council has no knowledge of, that hospital must answer. If they fail to answer, the hospital will be cancelled. The license will be withdrawn, and the donor and the recipient will be brought to question. They will not remove the organ, but that organ will help them survive in Ruzira. Okay.
Yes. Thank you so much, Doctor. Doctor, what do you have to tell to the public out there regarding organ transplant?
Thank you very much. Not only the conversation about transplant is taking place, which is very good in itself, and it's been taking place since 2014, 15. I know around 2016 we are promising this year, but it's now closer than before. I'm glad we are talking about it, but I'm also glad that certain fundamentals have taken place. Like I've said, we've got a unit that is completely irreversible. Now we have a law in place that's also completely reversible. We've got doctors who are trained and nurses. That's also irreversible. They haven't yet completed, but that's irreversible. Once we have got the transplant, the maiden transplant taking place, Then we move into phase 2, when we now have a regular transplant program. Okay? Once the regular transplant program takes place, we'll meanwhile be running the living donor program as we set up ourselves for the cadaveric program. As I've said, the cadaveric program requires us to have a waiting list, requires us to educate the people so that we've got potential donors whose names, the good thing, the national IDs are expiring in 2024, something like that.
Yes.
So by 2024, when we have new national IDs coming, hopefully by that time we'll have people saying, we'll leave a gap for organ donation, and those who have consented, it can be indicated. I know passports are renewed every day, that's done, and so by 2024, in the national IDs, in the national passports, and the driving licenses, we should have a slot for donors. So 5 years from the maiden transplant, hopefully we should have a cadaveric program in place. Once we have got a cadaveric program starting, we move into phase 3, when we can roll it out of Mulago to other units, accreditation. So then many people want to be accredited. Rubaga wants to be accredited, IHK wants to be accredited, Nakasero wants to be accredited, you know, Novik wants to be accredited, Mbarara wants to be accredited. All those will then roll out. Of course, there are no hard timelines, but that's how I'm looking at it. We've talked about it. That will end when you have the maiden transplant. After the maiden transplant, we establish a cadaveric program, and we also roll out. I am happy to live in these times, and one of the indications that we're a middle-income country is to have programs like so. So I still think we are in transit. When we transplant, then we'll have truly arrived in the middle-income status. And I'm glad to be living in this time and to be part of this process. So thank you.
You're watching Health Garage.
Welcome to the Mulago National Referral Hospital state-of-the-art dialysis and transplant theatre located on Block A, Level 6. Explore with us as we take you through this cutting-edge facility featuring advanced transplant theatres, intensive care unit, high dependency units, and specialized dialysis units.
These are dialysis machines. This is basically the filter. Now this filter, the patient's blood has to pass through this filter for a period of about 2 to 3 hours. And it's being cleaned and returned and cleaned and returned and cleaned and returned. This is what works in the place of the patient's kidney and removes all the impurities. When a patient has got end-stage kidney failure, it means their kidneys are not able to remove the impurities. They must have dialysis twice, preferably 3 times a week. But once you have on end-stage kidney failure, it basically means you need a kidney. So every patient whose kidney has failed completely requires a new kidney. Each machine can potentially run 3 sessions a day. So we can do 75 sessions per day. So in here is the transplant theater. We specifically put it close to the dialysis unit because they are interrelated. We are going to begin with the kidney. It has been transplanted, fails, then the patient returns on dialysis. So these 2 units really need to be together. In the ICU, they will basically spend about 10 days, 7 to 10 days. The patient will spend 7 days. The donor will spend about a day or 2 because they have not been very sick and they go to the main ward. Once the donor has left, then theoretically you can transplant another patient. Down the road are the theaters. We probably will not get there. But this whole place is cut off. It's got laminar flow air. Laminar flow basically means fresh air comes from up and then it's being sucked from below. So dirty air, which has got, like I'm talking now, what the organisms coming from my mouth don't go up. They fall down and they are sucked away. So fresh air comes up and warm and dirty air passes down. So welcome to the transplant theatre. This is the standard transplant theatre. You must have 2 operating suites adjacent to each other and communicating with each other. There is a door which can be closed, but during transplant it is actually kept open. The donor will be here and the recipient will be there. The donor is here because the donor surgery ends quickly and he has to leave, or she has to leave, and the recipient remains as they are completing the surgery. But to open the abdomen of the recipient, of the donor, the people who are going to receive should have opened and they agree that it is okay to go ahead with the transplant. Sometimes you plan the surgery, but when you open you find other things. So between the 2, we usually begin with the recipient who is sick anyway. We open, inspect the veins and arteries and say, okay, they are good, so start that side. Now here they start. Once they've exposed the organ, the kidney in this case, and they are ready to cut it away, again they must talk to the people who are there if they are ready to receive the organ. Now without this kind of arrangement, you cannot carry out a successful transplant. You may do some transplant, you may do something, but to have a successful transplant, you need this kind of arrangement. Even when you have got the cadaveric program where you're bringing the brain dead person, again the recipient who is in that hospital. So for instance, if you're going to give the heart to the patient here in Mulago, the recipient must be there, the harvesting is done here. Then the organs which are going to be shipped to other hospitals, the containers are there ready. So when you remove the organ for this, you put, they go. Put, they go. For this one you put, they continue. All this is done to minimize the time, what I call the cold ischemic time. The time between when you close the blood from going into the organ to when you open it after you have anastomosed the recipient. So these whole stories of they have knocked him, they have moved the organ, they are not sustainable because you cannot deliver a viable organ if you are doing quara. And you must have teams. At the harvest, you must have at least 2 transplant surgeons. Because once you start and one falls sick or something happens, the process must continue. So you must have 2 transplant surgeons, you must have an anesthetist, you must have nurses. You don't have less than 8 people on this team. Similar on the other team, you have not less than 10. So at any one time, you don't have less than 20 people participating in the surgery. So if you're doing illegal something, all those 20 people must be in on the secret, keep it, and if you're doing it again and again and again, it is very hard to keep it tight. In 20 people here, another 10 people on the ward, another 5 people in the transportation, the rate at which Ugandans speak anyhow, you cannot keep them shut. And what kind of money do you have to keep 20 people here kept shut? You tell them, oh, they've given me $2,000. And they say, no, no, they've given you 200. You know. So, really, it's teamwork. And besides, when you look at the penalties, someone being deregistered, all in the name of what? If you have the skill, why not do it properly? And get, even if you get $100 or $500, why not wait and do the little money slowly by slowly? So this here is mounted with the camera so that if you're operating and you have got students to teach, they don't have to all crowd under this bed screen. So if there is a supervisor who is watching what you're doing or a student who is watching what you're doing, they can only look there. Plus, this shot is transmitted electronically to a room. Actually, that's the whole name of theater. It was like watching a play going on. So it's supposed to be transmitted to another bigger room where theater is not taking place, when surgery is not taking place, and they watch every step of the surgery. So this goes to show you how state-of-the-art our theater is. But as far as infrastructure, you can put a huge tick on that one. While doing operation, you can get a YouTube clip like to help you with the surgery. So this should be the donor theater, and it is this position so that the donor, when they are done, they can exit and the surgery continues and receive the communicated stroke. And at this point, you have the perfusionist. The nephrologist receives the kidney. This is a fully fledged intensive care unit. If when the patient comes from theatre having been transplanted, they must remain here for about 7 to 10 days. The reason is not so much for life support, but in case we also need life support, we've got the systems. These are pumps. We have capability of having a ventilator, but mostly it is for isolation. Patients who have been transplanted are immunosuppressed, so they cannot mix with the rest of the population. We need to keep our kidneys healthy. The easiest and quickest way of keeping your kidney healthy is by drinking water. Minimum 2 liters per day. That's the quickest and easiest way of keeping your kidney healthy. The others are exercise, don't self-medicate, medical checkup, early diagnosis of diseases like diabetes and hypertension, and appropriate treatment for those diseases. If you've clocked 40, if you're into 50s, please get regular checkup. But bottom line, drink more water. The more water you drink, the more you flush your kidneys and they remain healthy and well.
We commend the government of Uganda for its unwavering commitment to quality health care, ensuring Ugandans receive world-class medical attention. Witness the precision and care that goes into every operation, every step, every procedure meticulously monitored for exceptional patient outcomes. The organ and tissue donation is permissible in Uganda. Following the successful maiden kidney transplant, Phase 2 is underway. This breakthrough offers hope for treating non-communicable diseases, saving countless lives. Stay connected with us. Send your questions and inquiry via our WhatsApp number on your screen. Thanks for watching. Join us next week. Keep it Health Garage.